Beautiful. And we take the discussion further with the second presentation by Yaron Zalel, someone I know already for many years. He's from Israel.
Don't say how many years.
I don't say, I don't mention. Otherwise we go again in the monsters sphere. Anyway, he will talk on early anomaly scan at 12 to 13 weeks, time to abandon NT scan alone. Well, while he's getting ready, I can tell you that obviously it all started with the NT scan, because that was the first moment that we started systematically doing a fetal scan in the first trimester to measure the NT. But he claims that we should go further.
I'll try
and
to
maybe
persuade
abandon it. I'm against, but...
I know.
Yeah.
We said how many years we know and argue nicely about it. So thank you very much for the invitation, Victoria and Tetiana, for the great work you've done, and Radu for the opportunity to be here again in Bucharest. And this is my talk, Early Anomaly Scan, Is It Time to Abandon the NT-scan Alone? And I have no conflict of interest, and I will try to persuade you in the next 25 minutes why is it time to abandon the isolated NT-scan and embrace the 12 to 14 weeks integrated fetal anomaly scan. And this is what we will discuss today. And I'd like to start with two cases of the same woman last year. She came first at March 25. She is 35 years old, has 3 healthy kids at home. She was diagnosed with increased NT elsewhere, and she came to early anomaly scan at 12.6 weeks of gestation. And that's what we have found. We have found the edematous face, the short nasal bone, the huge cervical cyst, along with VSD, reversed A wave in the ductus venosus, the echogenic bowel. Can you turn off the lights, please, here in the stage, that we will be able to see more the ultrasound images? Thank you. And this was a Down syndrome case, 12.6 weeks of gestation. She came back on December 25. This time she came straight to NT and early anomaly scan, 12.2 weeks of gestation. And that's what we have found. Clenched hands and fixed legs. Thank you. Yeah, it's much better, yeah. Abnormal face, absent nasal bone. You can see the omphalocele with a single umbilical artery, along with AV canal defect, 12.2 weeks of gestation. And this time, this was trisomy 18. So this case, this woman emphasized the need in combining both things. And we know that everything already goes to the first trimester. The horses has already excited the barn. And as Nicola said, the history belongs to Kippos Nicolaides, who started the NT as an isolated marker and stated the turning the pyramids. But let us show some cases that all came for NT scan, or the NT was evaluated 2 to 14 days before arrival. And all cases came for NT scan. The first one, 11 plus 5 weeks of gestation, 25 years old, primipara. And that's what we have found. Nicola has already shown you this case. You can see the ectopia cordis. And along with omphalocele and ectopia cordis, this was a case of pentalogy of Cantrell, 11 plus 5 weeks of gestation. Another case that came to NT scan, which was normal, 11 plus 5 weeks of gestation, normal NT, but you can see the enlarged bladder, the keyhole defect, the huge the huge umbilical cord cysts, normal NT. These cases came after normal NT elsewhere, and that's what we have found. AV canal defect at 13 weeks, Down syndrome after normal NT. Another case of normal NT at 13 weeks with low PAP-A, and that's what we have found. The deviation of the heart, fibroelastosis in the smaller left ventricle, along with, look at this vascular abnormality or aberration, umbilical cord to IVC. It will repeat itself in various chromosomal abnormalities. And this fetus had also bilateral polydactyly, clenched hands, bilateral cleft lip and palate, and absent nasal bone. And this was a case of trisomy 13 at 13 weeks of gestation. Another case of normal NT, 40 years old, 13.2 weeks of gestation, normal NT, and that's what we got, hypoplastic left heart at 13.2 weeks of gestation. You can see the hypoplastic left heart. These cases all came after normal NIPT. I won't go further because I have a special lecture about it, but they came after normal NIPT and end with termination of pregnancy. The next cases all came with increased NT and were sent to CVS but came to early anomaly scan first, or even came with normal CVS. And all these 5 next cases were found with holoprosencephaly. Let's see the first 3. She was 39 years old, 11 plus 4 weeks of gestation. And that's what we have found, holoprosencephaly, along with, you can see here, the proboscis. You can see in the next image, you can see the proboscis, 11 plus 4 weeks of gestation. The next case, 42 years, and at 12 weeks, she was found with increased NT, sent to CVS, but came to us first, and that's what we have found. Early IOGR, increased NT, holoprosencephaly, with limb deformities, and complex heart malformation. And the last of these 3 cases was 43 years old, 12.3 weeks of gestation, increased NT, sent to CVS, but came to us first, and we have found holoprosencephaly along with arynia. This fetus had also AV canal defect, and the 3 cases terminated the pregnancy due to trisomy 13 or trisomy 18. And the last 2 cases of holoprosencephaly, the first one, 35 years old, gestational age was 12.5 weeks of gestation, and that's what we found. Hip holoprosencephaly, abnormal posterior fossa. You can see the large head to abdominal ratio, clenched hand, prominent forehead, and low set ears, along with AV canal defect, and again, look at the umbilical vein to IVC. And this was a case of triploidy at 12.5 weeks of gestation. And the next case, the same pathology, 36 years old. She was found with increased NT elsewhere, and she came to early anomaly scan, and that's what we have found, holoprosencephaly, along with proboscis. And you can see the hydrops, the omphalocele, and you can see the molar changes in the placenta. And this was another case of triploidy, along with heart defect, triploidy at 13 weeks of gestation. And this is our study about prenatal sonographic feature of triploidy at 12 to 16 weeks of gestation, along with Moshe Bronstein. Another case of increased NT that was sent to CVS. She was found with septated cystic hygroma. She came to us on the morning when she got the normal QF-PCR. And that's what we have found, severe arthrogryposis. You can see the flexed, clenched hands and feet. along with complex heart malformation, and the outward repose is here, as you can see here, and she terminated the pregnancy. And another case that came to us after normal QFPCR, and that's what we have found, hypoplastic right heart at 12.6 weeks of gestation. This is an increased NT along with a triad, and this triad includes omphalocele. This case is also heart defect, but the omphalocele with enlarged kidneys and polydactyly, and this was a case of Meckel-Gruber syndrome, right, at 12.6 weeks of gestation, this triad with increased NT. Another case of increased NT, we found NT along with clenched hands. You see the clenched hands and the micrognathia, and this was a double trisomy case, trisomy 18 and Klinefelter all together. So all these cases came to NT, or had normal NT or NIPT, or were sent to CVS due to increased NT, or even came after normal CVS. And that's what we ask, is it time to abandon NT scan alone? And we have to ask ourselves, are we capable of providing anomaly scan so early in pregnancy? And you see the study by Singelaki that found 43.6% of the fetuses with non-chromosomal abnormality that were detected at the 11 to 13 weeks of gestation. I have moderated the session at the AIUM at 2014. The name of the session was Everything Leads to the First Trimester, and back then my study was increased NT to scan or to karyotype. The group of Katia Bilardo has found that an early scan performed by competent sonographers can detect about half of the prenatally detectable structural anomalies and 100% of those expected to be detected at this stage. Benoit stated that it is possible to see the major fetal abnormalities during the first trimester scan. And Karim et al. Lately found overall 32.7% of anomalies that were detected before 16 weeks of gestation. So this is the advancement of the evolution of the integrated care from Bronstein through Zalel to Yagel, and we'll go through. Yagel was the first to introduce in 2008 the utility of detailed, not Yagel, Bronstein, sorry, the utility of detailed first trimester ultrasound examination performed upon detection of abnormal fetal nuchal translucency. He had 37 cases with NT over 4 millimeter. 27% of them were found with major anomalies. The rest underwent CVS, which was abnormal in 33% of cases. Our study has evaluated the added value of detailed early anomaly scan in fetuses with increased nuchal translucency, and that's what we have found. We evaluated NT over the 95th percentile between 12 to 13.6 weeks of gestation. We had 43 patients. 70% of them were found with major anomalies, and the karyotype was abnormal in 40% of cases. So we have found that major anomalies were a strong predictor for aneuploidy with odds ratio of 8.15. And we concluded that the increase in NT to scan before karyotype, and we recommended very early meticulous transvaginal scan in these cases before CVS. So let's ask ourselves, if we are capable of introducing early anomaly scan in cases of increased NT with a mean gestational age of 12.4 weeks, why not to extrapolate it to every pregnancy at 12 to 13 weeks? And this is the various study in the literature of detection of early anomaly scan, and it varies between 30 to 70% of cases. Let's see some anomalies in the first, or syndrome in the first trimester. Anencephalus or acrania between 11 to 13 weeks of gestation. Early NTD, Chiari malformation. Amniotic band syndrome. And you can see another case of amniotic band syndrome with deformed limb in the first trimester. And in the differential diagnosis of this is a body stock anomaly, or as Bornstein calls all this syndrome as midline disruption syndrome. And this is our case of body stock anomaly. You can see it at 12 weeks of gestation, 12.3 weeks of gestation. And when I brought these volumes to Benoit in Monaco, these are the 3D structures that he created out of these volumes. Facial abnormalities like cleft lip and palate. We have shown micrognathia in the first trimester. Early skeletal dysplasia, this is a case of osteogenesis imperfecta type 2. And this is a case of ectrodactyly, ectodermal dysplasia clefting syndrome. You can see the clefting of the hands, and you can see the post-mortem finding, the pre- and post-mortem finding. You can see how similar it is. Polydactyly, pre- and post-axial dactyly. And some geo-tract cases. This is a posterior ureteral valve at 14 weeks of gestation. Look at the huge bladder and the abnormal kidneys. You can see the keyhole defect. And this is a so-called posterior ureteral valve, but it was a female fetus. You can see also the huge bladder and the abnormal kidneys. And this is a very interesting case that Katia Bilardo knows it well. This is a fetus that urinates something, 13.1 weeks of gestation. And you can see the huge bladder. You can see the enlarged bowel. You can see the enterolithiasis in the bowel and the phallus-like structure. The karyotype here was a female karyotype. So what is it, this case? Yes, it's a cloacal abnormality. It's urorectal septal malformation sequence. You can see it in the Vizug encyclopedia. And this fetus was urinating feces. I have a special lecture on congenital heart defects, so I won't go through it. Just to show you how we determine the situs, the abdominal thoracic situs, and I will go through it in the lecture of the heart. But this is a case of situs ambiguus and truncus arteriosus heterotaxy. You can see the heart on the right and the stomach on the left. Let's move forward. So what is the advantage of early scanning? When the scan is normal, so it's a great reassurance to the patient. When it's abnormal, it enables us early counseling, early CVS, frequent follow-up, and early termination of pregnancy when necessary, with much less complications due to earlier termination of pregnancy. What are the disadvantages? There is a loss of screening advantages, the training of the staff, appropriate equipment, and it might be too early, as Bornstein says, for hydrocephalus, gallbladder, gender, and cervical incompetence. And as Yagel stated, we will never reach 100% in early pregnancy because of the small size and the nature of developmental malformations. So one example of abnormal fetus after normal early scan with pericardial teratoma. Einstein said that if you can't explain it simply, you don't understand it well enough. I'm not finished yet. Singelaki stated that she found 27.6% of cases were detected in the first trimester scan. So how do you explain the studies by Bronstein and Zalel to Singelaki study? I explain it by two major differences. 11 weeks is not the same fetus as 13 weeks, and the early transvaginal scan is much more accurate than transabdominal scan. Yagel has wrote an opinion of integration of anti-screening into the FAS. The time has come. He said that early screening, while CVS is still an option for invasive general testing when necessary, is the goal, and the time has come to integrate NT into the early first trimester. Suoka stated that while initially the 11 to 13 week scan was performed with the sole purpose to measure the nuchal translucency, calculated the risk for Down syndrome, it evolved over the years to become a full anatomy check of the fetal organs. And this is our last study from 26, the detailed fast during the final NT window, 12.5 to 13.6 weeks, is non-inferior to the two-visit approach. We have to remember that we have to add in the genetic evaluation the CMA, it adds 3 to 6% of yield, and the exome, the WES, it has 8% of overall diagnostic contribution. And these are the summary of the studies of integration of NT and FAS, and this is a diagrammatic show from Bronstein in 2008 to the last study at 26. And the last case that emphasizes our message, septated cystic hygroma, she was sent to CVS, and at 13 weeks we saw her before CVS. You can see the edematous hydropic fetus. You can see the cetus ambiguous, the heart on the right, the stomach on the left. You can see it perfectly well here, as well as AV canal defect. And this was the case of, again, the umbilical vein to IVC, as I shown you, repeats itself. And this was the case of right isomerism and Turner syndrome at 13 weeks of gestation. So this is my clinical algorithm. The patient at 12 to 13.6 weeks performed NT and early anomaly scan. If it's abnormal, go straight to invasive testing and the route to early decision, if necessary, termination of pregnancy, which is much less dangerous. If it's isolated, increased NT, in most cases, the pregnancy will be well. The fetus will be delivered in term and well. And to summarize, most anomalies can be detected early. Normalcy brings profound reassurance, and the abnormalities allow early decisive action. Not every time we had the lucky of early ultrasound, so there were much surprises in the delivery room. And this is my final verdict. It is time to abandon the isolated anti-scan. I invite you all to join. You can take a picture of this to the Facebook group, Ultrasound in Obstetrics and Gynecology, where you can find their interesting cases. And I thank you all for listening.
Thank you very much for this very comprehensive lecture. In actual fact, you have covered everything, all the possible knowledge on first trimester. So I agree with you in actual fact that it's time to abandon the scan for only DNT. We should look at the whole fetus. What I disagree a little bit is on the fact that it should be a very, very extended scan, because obviously in a private setting that's possible, but we have to think of what we can offer to all the women, and then that makes a little bit of a difference. But let's move forward with, again, focusing on one aspect, and this will be first trimester neurosonogram, and again by Nicola, who is a great expert on this subject.
Thank you very much.